Okay, so I'll dive in with general observation. I'm quite happy to take questions as we go. Fairly free and easy about it. Don't stand on ceremony. And if you need a break, just let me know. Okay. So, when you meet your patient, you've got your first opportunity to start your observation. If they're ringing your doorbell or if you're picking them up from the waiting room, what do they look like? Do they look hot and clammy, cold, shivery? Do they look as though they're hunched over in pain? Is there anything unusual about them? When they're walking, if they stand up, is there anything odd about them? What's the posture or their gait? If they shake hands with you, what's the handshake like? All of these sort of things might give you clues that something's happening in the background. What's their breathing like? Can they breathe and talk at the same time? That's quite a good giveaway. If they're having difficulty talking to you and breathing. And when they're speaking to you, is it coherent? Because we might be dealing with some kind of issue involving the brain where their processing is out rather than a purely physical thing. So all these things might be of interest when you... once you've got over the introduction and the initial sight of the patient, obviously you're going to be taking the history. And once you've done that, you will be doing a more formalised observation once you've got the patient appropriately undressed and ready to work with them. So what we normally suggest is that you have a routine and start with the extremities. So you can look at hands and feet. You're interested in signs on the palm of the hands, soles of the feet, on the back of the hands, particularly on the nails. If you have any kind of edema, any swelling, if the patient is able to walk, has come into you on their own feet, if they've got any edema, it's likely to be around their ankles. So when you're looking at their legs, look around the ankles and you can check for pitting edema. If you were doing a home visit, or if you're in a hospital or something and the patient is bedbound, edema is more likely to show around the base of the sacrum if they're in bed. It will go with gravity, so wherever gravity pulls the fluid, that's where you'll see it. Having started with the extremities, then you can go up each limb looking for anything out of the unusual, out of the ordinary. What I would suggest is that you don't look for something. Have it in your mind that you're looking for a particular thing. Just look at what's there and note it, either mentally note it or in your written notes. And then once you've got an overall picture, you can try and work out what all the parts of the picture mean. If you go with too fixed an idea at the start, you might just focus on that and miss something else. So try and, at this stage, have a kind of wide view of the patient and just pick up what's there, and then you can compartmentalise it later on. So the sort of signs that you might be looking for on the palm, palmar erythema, there's a redness over the palm area, and you can get the same thing on the soles of the feet. And if you've got that, that is a sign that potentially there might be liver dysfunction. Another sign that you might see in the palm are these fingers, the little finger and the ring finger, being kind of curled in like that. And that's because of contracture of the connective tissue here, which is called Dupuytren's contracture. And again, that is related to liver issues. Again, as I said before, what you see in the palms, you can equally see on the soles of the feet. It can be either, it can be both, and it doesn't have to be sides. These things can individually, and there seems little or no logic to it. There's various things that can happen with people's nails. You can get the nail onycholysis, is the nail almost delaminating, breaking up. That sort of thing can be caused by fungal infections or physical injury to the nail. Most of these on that side are not are not signs of particular pathological problems, but they can be related to infection. They can be related to some defect in the way that the nail bed was formed, or they can be related to some kind of mineral or protein deficiency in the diet. Yellow nails can be, the obvious one was nicotine, again from various infections, fungal infections. If you get liver or kidney disease, that can leave things like bilirubin in the system or uric acid in the system, which can also colour nails. So just be aware of some of these things. The ones that are more indicative of particular pathologies, leukonychia, the white nails. With this, we're not talking about the little white flecks that you often get on the nails, but it's almost as if there's a chalky deposit underneath the nail and on top of the nail bed. And that is deposits of albumin, which can be caused due to liver malfunction. And if it's there, it's likely to be widespread. You'll see if you Google image it, you'll see lots of different presentations of it, but it is fairly definite that there is a white deposit, powdery-looking deposit beneath the nail, and it's not just the common little white flecks that people see. This other one, koilonychia, the dishing or spooning of the nail. If you look at your nails now, you'll find that there's a nice convex curve. So if you imagine dropping a little drop of water on there, it would tend to run off. With this koilonychia, instead of having that nice convex shape, you get a kind of dishing, a little bowl, so that your drop of water would be happy to sit in the little bowl. And that is often a sign of iron deficiency anemia, if you see that. Clubbing, that's a late stage of clubbing of the nail. You'll probably remember in your training doing this sort of thing, holding your fingers up to the light and seeing the little diamond of light. What you've got there, again, feel your own nail. If you press on one nail with the tip of another nail, right at the bottom where it goes into the cuticle, you'll feel that's very, very firmly attached. And the nail dips in just below the cuticle, leaving a little angle, and then when you put the two together, you can see that vague diamond shape between them. An early sign of clubbing of the nails is when that very tight attachment of the nail there is lost, and the nail lifts a little bit off the bed. So if you press it, it's a bit like pressing it on soggy tissue paper. It kind of squidges a bit, and you lose that little angle. And that is, when I first started doing this, all we could say was that we don't know why it happens. We've just noticed that it does happen, and that there's a kind of correlation with this phenomena and various pathologies. Now, the reason for it is clear, but it's difficult to explain. I tried to look it up, and you get about 5 pages of biochemistry explaining it, and I couldn't reduce it down to a noddy's guide to say this is what happens. But effectively, you get changes in at a cellular level, you get changes in the amount of fluid that is inside and outside cells, which leads to this kind of bogginess under there. And then you get a deposition of various proteins around the area, which eventually change the shape of the nail to make it look more bulbous, and then it tends to kind of hook over like that. So if you're desperately interested and can get through 5 pages of biochemistry, you can look up pathophysiology and nail clubbing, and if you can condense it down into a paragraph, please send it to me, because I love it.
Would you only see that in fingernails, not in toenails?
No, any of these you can see in toenails as well. And it's, as I said before, there doesn't seem to be any hard and fast rule. You might get it on some, not on others, hands not feet, feet not hands, one of each, whatever. It can be any kind of combination in there. And it seems to be the body's response to a chronic inflammatory condition. This is why you see the clubbing. When we were teaching at undergraduate level, we asked the students to pick up maybe 2 causes of it for each of the systems. It's not related to a particular system. It seems to be any system can have chronic inflammatory conditions, and it's a reaction to the chronic inflammatory condition rather than the particular system that causes the clubbing. Okay, so just recapping, you look at it, if you push on the base of the nail, if it feels a bit squidgy, that's called fluctuance, and that's an early sign. If you do that and you lose the diamond of light, that shows that the nail has lifted from the bed there, and in a late stage you might get this enlarged end of the digit and the kind of beaking over of the nail, which goes on there.
Do you get the same in hands and feet as well?
Yes.
Okay.
Yeah.
So I've never noticed it in someone's feet, but I see it as people's fingernails sometimes.
Yeah, it can be in hands or feet or both or either, whatever. The first thing that you should ask if you see somebody with clubbed nails is, how long has that been with you? And if they say, oh, I've always had that, you needn't really bother about it. Or if they say, oh, it's in my family. There are some families who have club nails as a matter of course. But if it's a new thing, then it may well be that there's chronic inflammatory condition going around there somewhere, which you might need to kind of explore into. This one, splinter hemorrhages. That little line there looks for all the world like a splinter underneath the nail. In fact, it isn't, but that's the cause of, that's why it's called splinter hemorrhages, because it looks like you've got something that's gone under your nail there. What causes that is, in bacterial endocarditis, a heart disease, the valves of the heart get infected, and you get little growths around the sealing surfaces of the valves, which are called vegetations. Now, they can disrupt the way the valve fully seals, but because they're being subjected to opening and closing all the time, bits of them can break off, and they can get around the system, and the they will flow through blood vessels until they find a capillary that they can't get through, and then they'll stick. Now, underneath the nails is your window on what the capillaries are like. So if you happen to have one of these things that manages to get to a capillary under the nail and sticks there, you'll see it like a splinter hemorrhage. It doesn't mean that they will automatically seek out the nail to go and squat under. They can go into any capillaries anywhere in the body, but if they happen to be under the nail, you've got a window that you can see them. That's why if they're there in the nails, they're likely to be widespread throughout the body in capillaries, but in areas that you can't see. And as I say, that's a sign of bacterial endocarditis. I mentioned before about pitting edema. This is the type of edema that's caused by too much interstitial fluid. So you've got somebody's, we said before, likely to be around the ankle, you've got them on the couch. If you press your thumb into the swollen area, it will make a little dent. And if you leave it there for a few seconds and then take your thumb off, the dent will remain and it will take a while to fill up again. Hence, pitting edema causes a little dent. And that's a sign that the edema is caused really by a condition which is causing some kind of fluid imbalance in the system. Typically right-sided heart failure, you don't get a good venous return to the heart, therefore you get, the body has to deal with more blood than should be in the peripheries. Some of that blood comes out in the form of plasma and goes into the interstitial areas, and so you get this build-up of fluid in there causing the swelling. It doesn't have to be heart disease, it can be liver or kidney disease. Anything that upsets the body's ability to regulate its blood flow, venous return or water balance in the body can cause that sort of pitting edema. Non-pitting edema can be caused by other things like protein deposits from various other problems. But the one that leaves the mark when you push the finger or thumb in is the pitting edema, which is likely to point you to either the cardiovascular system, the renal system, or the hepatic system as an issue. Other signs that you might be looking for, remember I said we look at the hands and feet and come up the limbs. You're going to be looking for anything out of the ordinary. In the circulatory system you might notice varicose veins. That's when the veins have become degraded, the one-way valves in them have stopped working. Normally the veins allow flow of blood towards the heart and the valves stop it dropping back again. If those valves become damaged, then the blood will tend to pull back, particularly in the legs, and stretch out those veins, distend them, and the whole flow of the blood back to the heart will be interfered with. If you see that, then it's a sign that all is not well with the cardiovascular system. Obviously, it's likely to be a fairly late sign, so you may find that the patient you're interested in has already told you in the history that they are under some doctor's care for their heart, in which case you probably don't need to worry too much. But if the patient is consulting you and hasn't spoken to anyone else about their cardiovascular system and you see evidence of varicose veins, it's probably not a bad idea to get them to go and talk to their doctor to find out the general state of their cardiovascular system.
Can anything else cause varicose veins other than cardiovascular?
physical damage possibly, but because the veins are obviously part of the venous return system, it's going to be something related to the cardiovascular system. I'm just trying to think if there was any kind of chemical damage that they might have had that would have weakened the wall of the vein, that might, so in other words, some kind of physical trauma to that area might have weakened it and let it through. Something like that, yeah. But in essence, what we're concerned about is that the whole system is becoming a little bit over degraded, and that's why we might think that it would be useful to have the system checked out to find out whether there's a central cause. Other things that you might notice when you're looking along people's arms and legs is any kind of muscle wasting. Muscle wasting might imply the interruption of nerve supply to that muscle, and that might be something that you're going to need to follow up. Also, unusual hair growth, rashes, ulcerations, any of these, anything out of the ordinary is worth you following up on, and just checking with the patient that they've not just sat there and ignored it, that if it's there, that it's being investigated and being dealt with. It may not be related to why they've come to you, and it may not mean that you can't treat them for something else, but it really ought to be drawn to their GP's attention to have it dealt with. Yeah.
With the varicose veins, would you, a patient with a collagen disorder like Ehlers-Danlos or something, would that be more likely?
I think it's possible because the collagen content of the veins might make them more likely to distend, so it might be a side effect of the normal condition that they've got. Yeah. So once we've done the extremities, arms and legs, come on to the head and face. So you're going to look around the eyes, around this area, around the cheekbones, around here, mouth and tongue, throat and neck, down to the clavicles. You might get this kind of malar flush, kind of butterfly-shaped rash going around there. From a cardiovascular point of view, that can be associated with mitral stenosis, but a similar rash can also occur in rheumatological conditions. So, again, if you see it, it's worth checking. Does the face look symmetrical? With this guy on the right here, the right side of his face is all completely expressionless. So what we've got there is a problem with the facial nerves, which deal with the muscles of facial expression, and that's typically Bell's palsy on there. Cyanosis. Cyan is a Greek, I think, word for blue, and this bluish tone is shown up when the blood that's reaching that area is not properly oxygenated. Either that or the blood isn't reaching the area at all. It can often be shown up in mucous membranes, around lips, or again around nails where you get that kind of window into the capillaries. And if you've got cyanosis, you might want to consider whether it's central or peripheral. Central cyanosis effectively means the blood is not being oxygenated centrally in the body. Maybe the interchange between air and blood in the lungs isn't happening properly, or maybe there's a blood chemistry problem that the blood can't carry the oxygen that is offered to it. But the blood is nevertheless getting around the body. So the area looks blue because it hasn't got oxygen, but is warm to the touch because the blood's getting there. So warm and blue implies central cyanosis. Cold and blue, the blue is because the oxygen's not getting there, the cold is because the blood's not getting there either. I mean, typically that would be a single artery that's occluded, and you would have the area served by that artery being cold and blue. But it could be a situation where the person was having very poor heart health, where the heart couldn't actually physically supply the peripheries of the body, and the body then kind of shuts it down to keep the circulation in the core, and the peripheries can look pale or bluish and feel cold.
When you're like super cold and your lips go blue, is that central or?
When you're super cold and your lips go blue, it's more likely to be a central. It's not likely to be a central cause in the way that I've described, in the sense of the lungs not oxygenating the blood. It's more likely to be the fact that the cold has shut down those peripheral arteries to stop it getting to the blood.
Yeah.
But it's probably central in the sense that it's not one limb that's got an occluded artery going into it, if you see what I mean. But just a transient thing like that wouldn't be a blood chemistry problem, and it wouldn't be a problem with the oxygenation or the heart not being able to reach there. It would be something like a local problem where the circulation had been shut down from an outside cause. Around the eyes, if you look at the conjunctiva, what's revealed when you pull your eyelid down like that, when you look at each other's eyes, you'll see what is a normal pink colouring. If that's pale, it's likely to mean that the blood is not carrying enough oxygen because of the lack of iron, so they're anemic. And again, that could be just pale, or that could be a bluish tinge as well because of the cyanosis. This one is, the baby's got the, unfortunately it's not shown very well on there, but there's a bluish tinge around the lips there, and that is a central cyanosis because the baby's got asthma, and the asthma is preventing the efficient oxygenation of the blood. So that's a sign of central cyanosis. In the area around the eyes, the picture on the left, the patient's right eye is normal, the eyelids are in the normal place. The left eye, you can see the eyelid is drooping there. And that's one of the signs of Horner's syndrome, where you get a droopy eyelid and you get a constricted pupil. The eye might appear to be slightly sunken in, and the other part would be that that side of the head, in that case the left side of the head around here, would lack perspiration. So you get this triad of ptosis, P-T-O-S-I-S, which is the droopy eyelid, meiosis, which is the constricted pupil, and anhydrosis, which is the lack of sweating on that side. And that is associated with a problem with the sympathetic supply to the area, and it's often caused by an apical carcinoma of the lungs pressing on the sympathetic ganglion. that area. And the slight sunken inness of the eye is caused by lack of fluid in the fat pad just behind the eye, so it looks as though it's sunk in. But they talk about the triad of ptosis, meiosis, and hydrosis, meaning Walker syndrome. Another thing around the eyes, if you look in this area here, 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 you've got these kind of yellowish white blistery looking things, and they are deposits of lipid around here. You don't see these so much these days, I think because GPs whack their patients on statins as soon as they get a chance. But I know my mother had them. I didn't know at the time what it was just the way she looked. But that was, they just look for all the world like little blisters, but instead of having clear fluid in, they've got kind of almost passy looking stuff in there. And it's just lipid deposits. But it does mean that their cholesterol is high, they've got hyperlipidemia. So you don't seem to see it as much these days as you used to. And there's another clue to that as well, I think it's on the next slide. Yeah, this corneal arcus, this thing around here, that ring around the iris of the eye. That again is lipid deposits around the iris. So hyperlipidemia there. The white of the eye should be white. If it's yellow, it means the patient's got jaundice, which is a problem that the liver is not dealing with bilirubin effectively. You can get yellowy looking skin from other things, even like eating too much carrots. But if you get the yellow in the white of the eye, then that's going to be jaundice. So what we've done here, we've done the legs, arms, we've come up around the head, we've looked at a load of signs around the face and the eyes, and we're now getting into the mouth. If you get them to show the tongue, when you look at each other's tongue, you'll see that it's got a slightly kind of corrugated surface and it's not shiny. It's got a pink coloration. If it looks slightly enlarged, it looks as though the skin is stretched over it, so it's got a slightly shiny aspect, and it's a deeper red. That's called glossitis. Some used to call beefy tongue. It just implies that there's an inflammation. Anything you see with glosso implies to do with the tongue. And in this case, there's a bit of an inflammation around the tongue. And it can often go with these cracks, infected cracks at the corner of the mouth, angular stomatitis. Stoma is a Latin word for mouth. The angles of the mouth are these bits in the corner, and itis just means inflammation, so it's just a translation of the Latin word for inflammation at the corner of the mouth. Both those things can be caused by lack of some minerals, vitamins, folic acid, things like that. The horrible thing there is just poor mouth hygiene. You can scrape all that muck off and keep your gums clean. It's fine. It's not a nasty, horrible disease. Perhaps a little bit more concerning is the underside of the tongue. If you get them to stick their tongue out and point it upwards to the top of their palate, the veins that you can see there, when you do it on each other, you'll see they just look normal. if they look enlarged and varicosed, then what you've got to realise is that those veins are the very top of a network, of a tree of veins that go down either side of the esophagus. So if the ones under the tongue are varicose, the chances are that the ones around here are varicose as well. Okay? Now, if you've ever seen somebody with varicose veins in their legs that has actually knocked them and torn them slightly, they bleed like anything. Okay? But it's very easy to fix. You just lie them down and elevate the leg and it will shut off. If it doesn't do that, you can just press on it a little bit and it will shut it off. But if you had that happen with the veins in here, how the hell would you shut that off? You can't really do much. If you lie them down, it's not going to make any difference. If you put any pressure on there, you're going to interfere with everything else they do. So you really don't want to do anything to this patient that might damage the veins in there, because they're going to have a lot of internal bleeding in that area. So that would be a danger sign for you if you saw those enlarged veins under the tongue. You would no doubt be able to question the patient and find out about their cardiac history, but I would suggest that your osteopathic treatment would be very circumspect about what you were going to be doing that might put any stress on that area. Throat and neck signs. In the main, in this area, we're probably going to be interested in what's happening to the trachea. It should be nice and central, and you can check with your own trachea. You can get a finger either side of it. If you couldn't get it in one side and you could get two fingers the other side, it looks like the trachea is shifted over, so you need to be looking at that. But the other thing in that area is the lymph system. You've got quite a few lymph nodes around here, under here, and you've got some very important ones above the clavicles. So any kind of odd lumps or bumps in that area, you would need to consider whether the lymphatic system is involved. There's the tracheal deviation thing I just mentioned about. So moving down from that area onto the surface, yes.
So the tracheal deviation would be a tumour?
Not necessarily. It can be something that's pushing the trachea over from one side, which could be a tumour. It could be to do with collapsed lung, pneumothorax, and the pneumothorax is a little bit of a difficult one to get your head around, because it kind of depends how the lung has collapsed. If the lung collapses because of the visceral pleura, the inner side of the pleura getting damaged, and the air from within the lungs leaking out into the pleural sac and causing the lungs to collapse, what tends to happen then is that the higher pressure from the other side will push the trachea over towards the collapse side. But if the lung is damaged by a penetrating wound from outside, so the outer layer of pleura is damaged, what can happen there is that the lesion, the hole that's made, can act a bit like a non-return valve. It's a bit like when you're pumping a bike tyre up. So when they breathe out, the air pressure from the outside pushes air in to the pleura from that side. When they breathe in, the hole seals. So they take their breath in, and then when they breathe out again, more comes in from the outside. So what you're getting then is the lung practically being forced flat by air pressure from the outside, and then it will push it over the other way. So it can be caused by pneumothorax, but the deviation depends on how the pneumothorax is being.
Anyway, you might want to send them down.
Yeah. And obviously, if, the first question was, could it be a tumour? Yes, it could. And if you're the first person to find that, then you would probably want to do the same thing. I mean, you might want to do a little bit more about trying to do a respiratory exam, which we can talk about. But yes, unless they're already being investigated for it, you'd be sending them off. Further down onto the chest, well, it can be this area and on the chest, you can be looking for spider nevi. A spider nevus is a little malformation of an arteriole, and they tend to look like a little red dot, which is almost looking down the artery from above, and a load of little spidery legs coming off, hence spider nevus. If you were to use a pencil or something and press on the red dot, then all the little spidery legs would blanch out because you'd be cutting the blood supply off. Now, these things are not uncommon, and the odd one or two don't matter. But the more you've got, the more likely there are to be, the more likely it is that there is a pathological cause for it, and the cause is likely to be a liver problem. The rule of thumb, effectively, the more there are, the more likely it is to be a problem. Rule of thumb, more than 6 above or below the nipple line, or more than 12 in total, is something that you might think is worth referring on. When you're looking at the chest and thorax, just be aware of any deformations, either congenital, as in this case, or due to injury or surgery. We don't know yet why we're examining this patient, but if you were concerned with respiratory mechanics, anything either a congenital deformity or scarring from surgery or deformity from an accident is actually going to affect how the internal organs work as well as the structure of them. And that would even apply to a scoliosis. If you've got somebody that's got a marked scoliosis, one side of the thoracic cavity is going to be compressed and the other side is going to open up. So that's going to interfere with the way they're using that, which you might be able to consider when you're doing your treatment. So the extreme examples that we've got there, but also the less obvious examples, if they've had any scarring from injuries of whatever sort, that might be something that you can bring into your assessment.
If it is, like you said, congenital, what's the cause of that?
Well, like in any kind of congenital thing, when embryologically we're laid down, the body's got a kind of map that it lays the tissues down in. If anything goes wrong with that at the early stages, it will lay down the tissues in a way that isn't according to the blueprint, effectively. What causes it? It could be the environment at the time. If the mother is not getting the right nutrients, there might not be as sufficient nutrients at the right time to do that. If the blood supply isn't sufficient, any of these things can happen embryologically and change the pattern that it goes into. Or if they've been exposed to some kind of toxins at the time.
It's just interesting to have a patient who is the father and it's gone down to the son. So it's just, the father's got it and the son's got it as well.
Well, in that case, it's more of a genetic thing, so the genetic coding is slightly different. And of course, with your genetics, there's no guarantee that it's about a 1 in 4 chance of anything going through, depending on how the eggs split, sorry, how the chromosomes match when the embryo is being formed. You've got 2 from the mum, 2 from the dad, and you get about a 1 in 4 chance of passing anything on, because you've got to get the right pairing from each one to get that characteristic through. But yeah, if there's a problem with the genetic code, then that would be the new embryo will be formed according to the forced code rather than the standard code, if you like. But that's a pure genetic one. But if the environment is wrong in utero and they're not getting the right nutrients, then it might not form at that stage. Yeah, so moving down onto the abdomen, again, you're looking for venous anomalies. And I'll rephrase that because I said before, when you do this, you're not looking for something, you're looking at it and seeing what's there. In this case, we can see that there's a number of venous irregularities on there. And that around the umbilicus like that is likely to mean that there's a problem with the portal system, portal hypertension. So the blood is finding difficulty in getting through the liver and back to the heart. So it's, if you like, it's queuing up to force its way through the liver. But it's got to go somewhere, it can't all just sort of stand and wait there. So it forces its way through ancillary circulation around the superficial veins, and that's what causes that dilation around there. So that sort of thing is an indication of possible portal hypertension. All this around here. This one here is an indication that the inferior vena cava might not be flowing properly. So that again, the blood is trying to find its way back to the heart through this superficial road rather than the inferior vena cava. Ascites, this is the collection of extracellular fluid around the abdomen. If you've got a distended abdomen, one of the things that we can test for in the abdominal exam is what's causing it. You might remember being talked about 5 Fs or 6 Fs: fat, fluid, fetus, flatus, feces, fetus, and fibroid. Yeah, there's 6 of them. So this is the fluid bit here. So that's called ascites. Again, you get that with when internal organs start failing. You get the problem of dealing with the fluid level. You get too much fluid in the system, so you get a load more into the interstitial spaces, and it comes up, and that's probably 2 to 3 litres of fluid that's spread around the body where it shouldn't be in there. Other things around the abdomen: scarring, surgery or injury might be relevant to why you're being asked to treat the patient. It's always amazed me that surgeons don't tell patients that the scars they leave might cause problems. And I'm sure you all have too, relieved a lot of patients' discomfort by doing work on scarring to stretch it out and make it more, make it less irritating to the patient. And also, if you see the site of the scarring, you might have some clue as to what might have happened underneath, and that might be relevant to what you're saying as well. This is an obvious problem, but you could be aware of any masses that are around. I mean, if you saw that, you'd run a mile. But when you are examining them, if you do see or feel something where there shouldn't be something, then get it checked out. I had a patient not so long ago, and it was someone that I'd seen quite a lot over the years, and normally I could help her by doing straightforward musculoskeletal stuff. But in this particular occasion, I couldn't really find a cause for the symptoms that she had. And she was also complaining of some gynae stuff as well. So I did an abdominal exam, and I found an area that I wasn't happy with. It just felt odd to me. So I wrote a letter to the GP and saying what I could feel, and I kind of, said it was 3 centimetres left of the umbilicus or whatever it was, and 5 centimetres up and whatever. And the GP took me seriously and decided to refer her, and she was referred to hospital. They did some tests, couldn't find anything, but they referred her for some more tests. They didn't find anything. Third series of tests found that she had got lymphoma, and I think with hindsight, what I was feeling was an enlarged abdominal lymph node, but I didn't clock it at the time. I just knew that there was something that we knew there. But it's quite interesting that we blame ourselves if we don't pick something up, but it took 3 lots of hospital tests before I got a diagnosis from it. But really, from the point I'm trying to make here is that is an overstatement of what's around. You may find something a lot less obvious than that still needs kind of looking at. This is a bit old hat now because most of the surgery is done keyhole, but with your more elderly patients, they may well have some of these more common older type scars. So having an idea of what the scars might mean might give you an idea of what might be going on and what the patient's missing if they don't remember what they've had done to them. So it's worthwhile having an idea of what's going on in these things. I know my dad had a gallbladder operation, and it went wrong, and he was on the table for 6 hours, and they did save him, but only just. After he spent a long time in intensive care, but when he got back home, he had a line straight down there, from about there to about there, and it looked like it had been sewn up with sack stitch. It was absolutely awful. Because I don't know what went wrong with the operation, but instead of sort of just being in there, they'd opened him right up. Anyway, that's... the other thing that's worth knowing about is the common sites for hernias. If the patient starts talking about lumps and bumps, it's useful to know what they might be at. While you're on the abdomen, it's worth considering AAAs. An aneurysm is a weakness in the wall of an artery which can cause that to balloon out. And weakness means what it says. You've got the 3 layers which are normally quite strong. If they're disrupted in any way, they do become weak, they do balloon out, and the area does become vulnerable. And when you're talking about the major artery out of the heart, if that actually breaks, the patient hasn't got very long to live unless it breaks on an operating table. So if you are concerned that your patient's low back pain might be being related to a problem within the abdomen, which might be a AAA, then I would suggest that you are quite circumspect in dealing with it. Look first, maybe squat down, get a skyline view across the abdomen. Is there an unusual pulsation there? It's not at all unusual to be able to see the abdominal pulse. And obviously, if the patient didn't have an abdominal pulse, they'd be dead anyway. So there needs to be an abdominal pulse, but it needs to be in the right place and the right size. If it is giving the impression of being expansile, coming out like that, it might make you think that there's a problem. The artery, the aorta, rule of thumb, think about 2 finger widths, the patient's finger width, going down just left of centre. If the pulse is palpable beyond that, then be a bit suspicious. Right. I was asked to do a research thing where they wanted to measure the aorta with ultrasound, and my aorta was 1.7 centimetres, which actually is substantially less than 2 of my fingers. So my rule of thumb was wrong with me, but certainly 2 fingers is probably not far out. They said to me that if it was below 3 centimetres, they weren't worried. If it was between 3 and 4 centimetres, they would monitor me. And if it was 5 centimetres, then they would operate. Now, frankly, if I thought my aorta was anywhere near 5 centimetres, I wouldn't be wanting to be kind of wandering around on the off chance that it might go. I'd want someone to fix it sort of earlier than that. But again, the books tell you that if you find the left-hand border of rectus abdominis, you shouldn't be able to palpate the aortic pulse lateral to that and an equivalent distance on the other side. You can kind of come in like that and get a sense of it. But I think if it was anywhere near 3, I'd be sending the patient to have it investigated and let the medics decide what is best to do about it. I don't think I'd be reassuring patients at 3 centimetres to be honest. Yeah.
Would you send them to A&E? Would you tell them to book with the doctor?
I think I'd tell them to book with the doctor for that. If it was 5, I'd send it to A&E. I think 3, I'd just say, I'd like you to go and see the doctor about that, just in case. And I think they'd have plenty of time to do an ultrasound and measure it then. But personally, I'd like them on the books at 3, rather than waiting until it got.
I've actually seen somebody who came with a back issue and had, he was a very elderly man, and he decided not to have his aortic aneurysm done. And it was the most fabulous experience, because you always worry, am I going to feel it or not? You can't miss it. Honestly, it's that obvious.
Yeah.
And I nearly had a heart attack. But he just said to me, it's all right, I'm quite happy if I drop dead on your table. I'm not worried. But it honestly is so obvious. So if you've ever felt a really large one, you won't miss it. And I've seen 2 or 3 people with smaller ones that have been well documented, and they're on the programme for having their treatment, surgery.
Yeah.
And again, you can feel it. It's quite
Yeah.
If you've not felt one, you will. If you don't worry, you will find it.
Yeah. The other thing that people get a little bit scared of, I've just said about the distance between rectus abdominis and that. But bear in mind the aorta stops being the aorta around about the level of the umbilicus, and then it goes out into the iliac arteries. So if you're below the umbilicus, and you're feeling it more laterally, then that's kind of okay. But you can still have an aorta in there. Sorry, you can still have an aneurysm in there. There we go. We'll skip that. Okay, so that's my kind of brief run through of about things on observation. That is not exhaustive. Okay, they were things to make you think. Anything out of the ordinary, maybe just investigate.